I have been thinking about this dilemma for some time. Why do we wait for 2 to 3 months before doing a vitrectomy for a diabetic patient with vitreous hemorrhage and sudden loss of vision?
We have to practice evidence-based medicine. The evidence shows that we should not operate till we are sure that the hemorrhage is not going to resolve spontaneously.
But the level 1 evidence from the DRVS is so old. Things have moved on. Technology and techniques have improved and results are better with highly reduced complication rates.
Oh come on. Surgeons just like to operate. We should not go outside clinical guidelines and evidence from randomized controlled trials.
Let's look at the old evidence again then. Eyes with severe vitreous hemorrhage actually did better with early vitrectomy even in that study from the ADS, but more eyes in the early vitrectomy group were ending up blind. And looking at eyes with useful vision and vitreous hemorrhage, again the eyes which were operated on did better, but sadly more eyes went completely blind in the early intervention group.
So you are happy to let some eyes go blind so that others can get a little bit better vision than they would have if we had simply waited before operating.
You are getting me wrong. My contention is that eyes rarely go blind from vitrectomy for diabetic vitreous hemorrhage today. Recent studies show that the rate of eyes going blind is near zero. Remember the DRVS was recruiting just a few years after three-port vitrectomy was introduced in 1975. Now we have 14 years experience with micro-incision sutureless vitrectomy, with wide-angle viewing, bimanual surgery and improved fluidics and which is much safer for the eye.
Maybe I should rethink my practice.
I am sure it will benefit all our patients with diabetic vitreous hemorrhage.